So I'll begin by thanking my mentor and my teacher, Professor Yashpal Sharma, under whose guidance and supervision this project was carried out. So we know that atrial fibrillation is the most common sustained arrhythmia, and the prevalence continues to increase worldwide. As such, both age and dementia, both atrial fibrillation and dementia increase with advancing age, but the relationship is more than just a mere coincidence. And research has pointed that atrial fibrillation confers roughly a 2 to 3 fold increased incidence of cognitive dysfunction. So why this happens is a matter of debate, and there have been multiple postulates. The commonest being beat-to-beat variability, resulting in decreased cardiac output and subsequently decreased CNS hypoperfusion. There has been theory of microcirculation dysfunction in the form of endothelial dysfunction, inflammation, circulatory stasis, and micro and macro bleeds, all of which contribute to ischemia and CNS dysfunction at the microvasculature. Amongst the recent data, as published in 2022 in Circulation, there's still factors that have been shown to have some association with increased dementia: a higher CHAST score, increased duration of AF, a younger age of AF onset, diabetes, and past history of cerebrovascular accidents. Only therapeutic anticoagulation as of now has shown to have a preventive role. Catheter ablation, still it is early days to comment on that. So why this study was needed? So we know practically there is no data on atrial fibrillation and dementia in India. We have large registries like Realize AF, Garfield, IHRS, but none of them have commented upon dementia, and it is even grossly under-recognized worldwide. Indian genetic makeup puts them at a higher cardiometabolic point of view, and as such, we need more data. Our progression shows cardiovascular diseases at a much younger age, and we have a much rapid progression as compared to the West. So we need our own data to determine specific therapies that are unique to our population. So this was a single-center prospective observational study in which anticoagulation naive or anticoagulation was taken only for the last 3 months were taken, and non-valvular atrial fibrillations were only taken, and there was no valvular atrial fibrillation patients recruited. So we screened all of them using a mini mental state examination. The first outcome measurement was to study the prevalence of dementia, and the second was to identify the independent risk factors that are associated with dementia. Inclusion, as I've already told, and we excluded all patients who were already receiving anticoagulation for more than 3 months, valvular atrial fibrillation, past history of cerebrovascular accidents, or mood or depression that could otherwise also lead to dementia. So mini mental state exam has already been validated since last 30 years and is widely used in clinical practice. It is a 30-point scoring system which is easy and repeatable and takes less than 10 minutes to be performed in an outpatient basis. So it has been widely validated, and also there are adjustments for education level of the patient. It roughly tests all the parts of the CNS comprehension, including calculation, attention, recall, registration, and language and orientation. So we had 108 patients recruited, and a mean population age was 66 years. Hypertension was present in roughly 70% of the patients. So in this, I want to highlight that we had a population that was at a higher risk of cardiometabolic risk factors, with 30% being diabetics and almost 70% being hypertensive. So as to the patterns of dementia, so almost 37% of our patients had dementia, and majority had mild cognitive dysfunction, and only a fraction had moderate cognitive dysfunction. So there was variable loss of CNS comprehension in different domains, and most commonly it was seen as attention and calculation deficits in almost more than 50% of the patients, followed by deficits in working memory and visuospatial deficits. So on univariate analysis, these are the 10 factors that came to the fore with a p-value of less than 0.05, and subsequently these were looked into further details under multivariate logistic regression. So we found that age, female sex, diabetes, an elevated pulmonary artery systolic pressure, and a lower serum albumin all were independently associated with dementia. So this is the forest plot, again highlighting the same. So I'll just take a minute commenting on each of these. Advancing age is understandable, as with age we have cognitive decline. So that is understandable. Presence of diabetes is an independent risk factor for dementia as such, irrespective of AF. Diabetes will lead on to microvasculature dysfunction and endothelial dysfunction. So that will again contribute to CNS hyperperfusion. Female gender is a recently studied topic, and in a recent meta-analysis by Chen et al., they found that female gender was independently associated with increased neurological complications, including both CVA and dementia amongst AF patients. Higher pulmonary artery systolic pressure is again like a moving target, so it is very difficult to comment on that because it is a dynamic thing. Maybe because they have higher functional status, higher functional NYHA class, and a lower functional status, or associated depression might contribute to this. Higher serum albumin generally represents a good overall health, and a lower serum albumin would accordingly mean a frail elderly patient who's otherwise having a reduced functional class. So why should we care about dementia? So we know that dementia not only worsens the quality of life, it also confers excess morbidity and mortality and incurs significant healthcare costs. There is excess dementia in AF, as has been shown in multiple Western studies. Even in our setting, we have very little data in India. So roughly the prevalence of dementia in India at 75 years is around 8%. This is a single study by BHU. Only this is the data that we have available as of now. It was again screened with the use of multi-mental state examination. So there is clearly excess. So we had a percentage of 37% at 66 years, clearly showing the sex dementia as compared to the general population. So this is incorporating all the evidence that we have from the larger studies as well as our own data, suggesting this is an original image. So we know that factors that improve cognitive function include, which preserve cognitive, I would rather say, therapeutic anticoagulation, aggressive risk factor modification, a good diet, weight control, adequate rate control, rhythm control, and most notably the recent of these, catheter ablation. And the factors that lead to excess dementia, of course, are advancing age, inadequate anticoagulation, obesity, diabetes, micro and macro bleeds, renal dysfunction, anemia also was an independent factor in the univariate analysis, female gender. So ultimately, all of these culminate in cerebral hyperperfusion, neuronal apoptosis, cellular loss, and dementia. So we have managed to publish this research recently as of last week. So in conclusion, I'd say that prevalence of dementia is increased among AF patients independent of age and past CVA. Dementia is widely prevalent but is grossly under-recognized. Factors that are independently related to dementia include advanced age, female gender, presence of diabetes, elevated systolic pressures at presentation, and a lower serum albumin. And we know there is a need for aggressive risk factor modification along with institution of effective oral anticoagulation in these subsets to prevent the further downhill course. Thank you.